Next, we have Christ Hospital talking to us about precision with Burns Blaxall? Yes, MD. And we need like a little bitty break for some AV so we can get his presentation going through.
Should go ahead and close this. We can just sit on top of that. Might slide. Well, put it up here. Yeah, maybe.
Put that one underneath.
Okay. Sorry. So, hey, perfect.
Check down here to make sure it's routed correctly.
Did you want the microphone or is the podium mic
I
okay?
can use podiums for things. Perfect. All right. Yay. Okay. Thanks very much for coming, everyone. I was informed about 10 minutes ago that the 30 minutes I thought I had was supposed to be 10 minutes, so I'm going to try to make this in 10 minutes. Again, thanks very much for coming, and thanks for having us here to talk a little bit about what we're doing in precision health at the Christ Hospital. Question number one, what is precision health? Two quotes that I like to use to define this. The first is from a fairly famous physician from a long time ago, Voltaire, who said that doctors are men or women who prescribe medicines of which they know little to humans, or for diseases of which they know less, in humans of whom they know nothing. And then the second is from one of the godfathers of cardiology, modern cardiology, Sir William Osler, who said that if it were not for the great variability among individuals, medicine might as well be a science and not an art. And we know that it's actually both. So in our view at Christ Hospital, excuse me, precision health is really kind of three buckets. So it's really, if you look at the bottom, it's really about shifting healthcare from reactive to proactive. So the first thing we do is try to evaluate hereditary disease risk up front, and I'll talk to you a little bit about that. And also we'll look at spontaneous disease risk, largely in cancer. The $10 word is pharmacogenomics, how genes impact the way medicines work in your body. And then the third is really looking at clinical decision support tools that are embedded in our medical record, and we'll expand on that a little bit. So the first, you probably have heard of genes like BRCA, and so there are several genes that can predispose people to hereditary cancer. So one of the things that you can do is you can ask patients questions to determine whether or not they meet guidelines set by the National Comprehensive Cancer Network, to determine whether or not they meet those guidelines for genetic testing for cancer. So what we did is we created an interactive chatbot in partnership with a company, Invitae. And this interactive chatbot asks patients a bunch of questions that determine, A, whether or not they meet hereditary cancer guidelines for genetic counseling and testing, and they also determine if they meet something called the Tyrer-Cuzick score, and that is basically a guesstimate of lifetime risk of developing cancer. So we did a pilot study in mammography because women are more proactive about their health, and in most households, over 80% of households, they make the healthcare decisions. So in 1 year, we had 20,000 women fill this out. We identified 5,100 who met the NCCN guidelines for genetic counseling and testing, a collective 2,400 who met that Tyrer-Cuzick score. So in 1 year, we impacted the lives of a lot of people. We're super excited about it. We've had over 30,000 women fill this out. Since then, we'll be expanding this out into women's health and ultimately primary care so that we can evaluate every patient in our health network. We have a lot of genetic counselors who can help talk people through what the challenges are with doing genetic testing, understanding the results, and how to proceed. And so this is what they do. And then another aspect of what we do, and so I guess I should mention, we've built this out for cardiology. We actually just went live last week with our interactive cardiology chatbot to determine hereditary cardiovascular risk, and we're doing a test on that. We also have an evaluation for prenatal and preconception. Another aspect of disease screening is in the healthy patient, so a patient who doesn't meet guidelines, and what do you do with them? So this is a study that was published just over a year ago, and there has been a follow-up since then where patients were handed a kit. They didn't meet any guidelines for genetic counseling or testing, and just about 10,500 patients were handed a kit, did a genetic test, and determined that among those patients who were healthy, didn't meet criteria for genetic counseling or testing, 15.5% of them had a personal risk for a monogenic disease, something like sickle cell, and a collective 6.2% had an actionable hereditary cancer or cardiovascular disease risk. To expand that out a little bit more, Intermountain Health on the west side of the country has partnered with Decode Genetics, and they're doing whole genome sequencing in 500,000 patients. In their first 150,000 patients, 7.2%, I believe, of their patients have an actionable hereditary cancer or cardiovascular risk. So we think this is really kind of the future, and we're pushing very hard into not only hereditary cancer and cardiovascular testing, but ultimately offering this to patients who might even think they're healthy. So we've also, along these lines, created a high-risk cancer screening clinic with advanced practice providers, and a patient who meets both of those criteria that I told you about will come in, same visit, same time, sit in a room with the advanced practice provider, talk about their cancer risk and the mitigation that we'll do for that, and then they'll also meet with a genetic counselor, do the genetic testing. In the healthcare world, we live and die by our patient satisfaction scores. Or Press Ganey usually administers these, and we are super proud of the fact that in our genetic counseling and high-risk cancer screening clinics, we have been in the 99th percentile since our inception, which means that patients really like this. Another piece of innovation that we're trying to develop is to ensure that we are up to date with everything that's happening in oncology. So oncology is a very rapid moving field. Last year, 15 new drugs alone were, or new indications in lung cancer were approved. It's pretty hard to keep up with all that. We've partnered with Dana-Farber Cancer Institute and Philips Healthcare to develop an interactive tool that data agnostically brings in every piece of data about a cancer patient, all their diagnostics, genetics, somatics, et cetera, puts them in one place, guides the clinical decision support, and then ultimately can help ensure that we are all up to date as much as possible in our cancer treatment. So now we're going to pause for an interactive audience question you do have to answer before I go on. What are the top 5 leading causes of death in the United States? Heart disease, thank you very much. Cancer number 2, a close second, but last year dropped for the first time ever. Reduction of numbers. Okay, so that's number 2. Number 3, I often tie with heart disease, so it's stroke. Number 4, anybody? Bueller. Sorry? Accidents, good guess. Anyone else? Also a good idea. It turns out that it is adverse drug events. 4th leading cause of death is actually intent to treat. I'm sorry? It includes overdose, but that's not the only thing that happens. An overdose happens because they got an original prescription most of the time. And what we'll talk about here might actually help explain that. So non-optimized medication is estimated to cost our healthcare system more than double what any other major disease does. And this might be why. So I sit on something called the Clinical Pharmacogenomic Implementation Consortium. It's an international group that drives guidelines for who should get tested when they take particular drugs. The FDA actually box labels over 100 medications that should get genetic testing before prescribing. 55 million patients in the United States take greater than 5 medications per day. I told you already it's the 4th leading cause of death. And in global studies, it has been reproducibly found that among the 23 genes that are known to impact these up to 100 medications and their processing and the way they work in the body, 99.2% of patients have a mutation in at least one of those genes, meaning that literally anybody could benefit from this. If you're wondering what drugs are involved, this is a nice list organized by disease state. And so there's a huge amount of possible impact that we could have here. In a few global studies, it's been found that 1 in 4 patients are taking a medication that it would be impacted by pharmacogenomics, and if it was done. And if it was done based on prevalence of mutations in global databases, 1 in 8.5 patients would have an immediate change in their dose or drug. So in our view, this is among the lowest hanging fruit in medicine today. One of the things that we can do with this data is we can take every medication on this list, and we can take the gene that we know that impacts that medication and evaluate a probability score. So we know the prevalence of mutations in the database, we know the drugs the patient is taking, so we can just calculate a probability score. We've developed that probability score, and we did a retrospective study, 100,000 patients, and we just asked very simply, what predicts an ER visit or a hospitalization? And so this is that list. It was done with an insurance company, so you see claims on here. On the bottom of the list, number 1, age is the number 1 predictor of an ER visit or hospitalization. Above that, number of meds you're taking is number 2. There's a bunch of insurance claims. There's chronic lung disease, which is 50% mortality at 1 year. The pharmacogenetic interaction probability score that I just explained to you in the top 2 quartiles predicts an ER visit or hospitalization better than hypertension, diabetes, kidney failure, heart failure, high cholesterol, everything on that list. It's absolutely remarkable. So why is that important? It turns out that we've surveyed 18 healthcare systems nationwide. 36 to 52% of patients in healthcare systems that we've evaluated fit into that probability score, which again suggests to me that this is probably among the lowest hanging fruit that we have in medicine today. So at the Christ Hospital, we actually have now 11 pharmacogenomic pharmacists. We have 6 embedded in primary care. Actually, just our 7th starts December 2nd. And then we have pharmacists embedded in specialty areas as well. And their job is to proactively, using this pharmacogenomic risk evaluation tool, evaluate the patients and recommend pharmacogenomics for those for whom it is warranted. We're super excited about this. So is the state of Ohio. They gave us their Pioneer Award for this implementation from the Ohio Pharmacy Association. The tool that we use for this, I grew up in a country where there's a single medical record. I think that's what we should have in this country. We don't, but we embed everything in the medical record, just like everything I told you before with the hereditary disease risk. We have a clinical decision support tool embedded in Epic, just like we did for that oncology portion. And this looks at all the medications a patient is taking, tells you what their pharmacogenomic risk is, says what drugs you should and should not be taking together, and looks at a lot of other things that I won't bore you with the details right now. So to this end, we are running the world's first prospective randomized controlled trial of comprehensive pharmacogenomic testing, 6,000 patients randomized based on their pharmacogenomic risk score, looking at primary outcomes of ER visit, hospitalization, 30-day readmit, and mortality. Preliminary data suggests we're reducing those by up to 30%. Why do we think this is important? The comprehensive testing we do instead of a single gene test or just a test in a particular disease area, because a vast majority of patients, 60% almost, are taking medications within 2 disease areas. So they have at least 2 different pharmacogenomic implications. Quick patient story, and I'm really fond of this story. So we have this randomized controlled clinical trial, and for the past 2.5 years, I've been working with several groups lobbying for coverage for this, because right now CMS does not necessarily cover it for you to see a pharmacist and do pharmacogenomics. So on March 24th of this year, with Representatives Swalwell and Emmer, we introduced the Right Drug Dose Now Act. And as part of that, on March 29th, this was the congressional testimony. And in the top right of your screen is our Chief Nursing Officer, Julie Holt. And I had just rotated out, she came in, and she was telling her story as part of the congressional testimony with these other faculty members from Mount Sinai, Pittsburgh, and Harvard. And her story is a simple one. She had 12 years of gastroesophageal reflux. She had seen 3 specialists, gotten scoped 4 times, tried 6 medications, had no alleviation of symptoms, was having symptoms 6 out of 7 days a week, bought the sleep sitting up bed, changed her diet, was getting no alleviation. She randomized to our trial. So remember, she's our chief nursing officer. She randomized to our trial, did pharmacogenomics. We got the data back. We changed her to an appropriate medication indicated by her genes. 2 days later, no symptoms, none for 8 months. So again, I think for me, this is one of the most exciting opportunities for us to advance medicine. Another thing that we can do is precision prescribing in oncology. So one of the things you can do in oncology is you can actually take the tumor itself and look for spontaneous mutations for new medications that target that specific mutation or indication. This is a story of a gentleman who came to us. He had a rapid onset tumor that looked like this, complete hearing loss. He had blood transfusions, recommendations from 2 outside hospitals for bone and bone graft and muscle graft. He would lose his hearing. We did the somatic testing for him, found the appropriate medication that would very specifically target his cancer, and this was him 8 weeks later. So there's a lot of developments in medicine that I think are really exciting. For me, the most important is this editorial from The Lancet last year. So precision medicine had its birth in oncology because of drugs that target specific mutations in tumors. And this was an editorial in The Lancet where they said, we're really excited about all the advances that have happened in precision medicine and oncology, but the reality is that of all the patients who should get that somatic test of their tumor to look for spontaneous mutations, less than 15% of the patients who should get it actually get it. So they talked very seriously about the importance of research and development, but most importantly, the implementation science. And that's really what we're focused on. We're super excited about the implementation. I'm running a little over time, so if you would like to see a 1-minute video, I can tell you what our future is, or I can just add video. Okay, cool. All right. So this is our 5-year plan. All right, thanks very much for your time. I appreciate it.